Bismillah ar-Rahman ar-Rahim. I welcome my all panelists, Dr. Atif, Dr. Gulzar, Dr. Bashir and Dr. Ammar. Today I am going to discuss a case-based scenario on saphenous venous revascularization. A dilemma addressed or to be addressed. Everybody have talked about the DK crash and all, nobody have talked about the saphenous venous graft. We know the natural history of saphenous venous graft. There's almost 15% of the SVG, they are occluded within 1 year of life, and almost 50% they are occluded in the 10 year after the surgery. They are high risk, mostly we call the SVG intervention is a high risk procedure. So I will start my presentation with the history. My patient is 70-year-old male, is diabetic and hypertensive from last 20 years. He had a history of cabbage 18 years back, and he was doing well from last 18 years, but from last 3 weeks he is complaining of the chest pain. That was CCS3 angina. It was mostly seen in the postprandial. It was diagnosed as unstable angina. On examination, he was hemodynamically stable. I've seen this patient on the OPD basis. His troponin was negative. Other labs was normal. Then his echo that shows preserved LV function, and ECG was not remarkable. So decided to go with the coronary angiography. The history of bypass graft was not available. There's no any paper, because according to patient he said that I received a 3 graft, so I don't know exactly which graft was used. So I choose the right femoral access. EDP was checked, that was 12 millimeter of mercury, and his right coronary artery, you can see this in a RA view, and in the LO view you can see it's totally occluded of the RCA from the proximal. And there's a slight collateral seen in the on the distal RCA. This is the left system. It was engaged with the Judkins left, and you can see there's a severe disease in the circumflex. There's totally occluded of the ostial of the LAD, and there are the faint collaterals filling the distal RCA from the OM branch. This is the cranial view, epicranial view. As see, there's a severe calcification seen in the LAD territory, and it was totally occluded from the ostium. There's the same finding can see in the elocranial view. There's a collateral seen in the RCA filling from the collaterals from the OM branch. So a spider view shows same changes. So the native 3 vessel disease, the CTO, RCA, CTO, LAD, and they also occlusion of the OM branch. I took a shot of Lima. I don't know it was either harvested or not. So I took a shot. You can see clearly there is a Hagar collapse seen, but to me, I think the Lima was harvested but not grafted. I don't know any reason, but there was no any surgical notes were available. So tried to locate the SVG graft, but I found, I'm sorry, I don't have a slide of RCA and OM. Believe me, it was totally occluded from the proximal. So the only graft was patent, that is the SVG to LAD. But you can see there's a critical disease in the ostium of the SVG, and there looks to me it's a fibrotic. And while engaging the SVG patient, pressure was damp, so I disengaged. Another view was taken slightly. You can see the disease in the SVG to LAD. So didn't take too much shot. This was the last shot. To me, the SVG is a critical disease. There are also collaterals, the retrograde collaterals filling the LAD from this SVG. You can see the first septal is coming here. There are also a retrograde filling of the OM branch in this, and you can see the RCA is also filling from this.
Dr. Jahangir,
I'm coming to you.
Was it difficult to engage that SVG to LAD, or did you deliberately did not engage it because of pressure damping?
Actually, I was afraid, because every time if there's any aorto-ostial lesion, there's a difficulty to engage one. Another, the chances of ischemia and the dissection are more. So you have to be very careful, because diagnostic etc. they are not too much soft, where the chances of dissection are more in this patient. So my question to the panelists, If you see this patient in your clinical practice, how you will approach for?
Okay, we can comment about this case. Is this patient is 70-year male and probably is diabetic and hypertensive and received these grafts about 18 years back. And probably this patient is compliant to treatment, having 2 SVG grafts totally occluded and with the one that is also degenerative. It looks like almost the angiographically 90 to 95% disease, aorto-ostial disease. Here for the discussion present, one can say that we will discuss this case in heart team, and heart team will advise this. The board of heart team is also consists of surgeon, interventional cardiologist, and imaging cardiologist. So here we can discuss about this patient that if I carry this patient during cath, I'm thinking that it's better to intervene the native LAD, but native LAD segment is lengthwise more than 20 mm 95 count. The JCTO score of this case is probably more than 2 or 3. So, and it's calcified. If I'll go with the intervention of the native LAD, it requires a lot of fluoro time, dye, and considering this, the aorto-ostial of the SVG, it's easy to intervene. So I'll proceed to intervene the PCI of SVG to LAD.
What about Dr. Ammar? What you would say after looking into this angiogram?
Yes, this is a very critical patient, and this LAD is the lifeline of that patient. As Dr. Bashir said, that attempting antegrately into the LAD is very dangerous, even by the dual injection if you give from SVG. So I think the case should be referred to the heart team, and we can give an option to the surgeon regarding what intervention he can do. But unfortunately, as we are seeing that the lemur is absent, and most likely if we can choose the lemur, then there will be difficulty in healing the wound. So the only option that left is the radial artery grafting, and that is again a high-risk procedure. So my comment will be that we should refer it to the heart team and let the surgeon decide, so patient have the option of both. Most likely it will go for the PCI of SVG to ostial SVG.
What about Dr. Gulzar? What's your comments?
I am totally disagree with Dr. Ammar, because for the graft intervention SVG, which patient go for redo and which patient go for PCI. These patients have a good EF, SVG to LAD, and other SVGs occluded. No lima is already harvested. You didn't see the lima, Jahangir. So I would go for the PCI SVG to LAD, but with the preparation, because it's only artery which patients on. So you can put IABP and backup supports with anesthetists. You can go for the PCI to SVG to LAD.
Dr. Atif, your final comment.
Yeah, I would say that in this case, the heart team discussion would have been the first option to start with. And I mean, looking at this LAD, which is disease-free from the mid to distal segment onward. So I think putting an arterial graft in the LAD would have been a better option. However, I really do not know the status of the lima, probably as you already mentioned, harvested but not grafted. But we have other options like rima, we have gastroepiploic artery as well, we have a radial artery. So I would say heart team discussion followed by probably cabbage.
Yeah. Can I just, Dr. Gulzar, you mentioned something about putting an IABP. Now, in vein grafts that go up and down, where is the predominant flow during the vein graft? Is it systolic or diastolic?
No, it's diastolic. I am not regarding the SVG to intervention for IBP. I am inferring because...
The first part of my question is, flow in this vein graft, would that be during systolic?
I understand your question. You are saying that IABP is favoring to the diastolic pressure in aorta, and in SVG it's systolic pressure. But I am not putting the IABP for SVG to LAD blood flow. It's just for LV support. In case I would do the PCI and I will shut down the SVG to LAD,
His
then
LAD.
what will be the fate of the LV? So that's LV will be the go to directly. This is the only vessel. It's the only vessel of this patient. So far, you are secure.
I completely agree with you. That was the only point I was trying to make. So you would use IABP
For
or
circulatory
LV
support.
to unload the LV
Yes.
in case it were to go down and not to augment coronary flow.
But
Were that to happen.
his LV is normal.
I think, but considering the scenario, if this patient came with cardiogenic shock with ST elevation MI, even having the culprit artery SVG to LAD, so what would be the strategy? Patient is in shock.
So, in acute MI
No,
cardiogenic shock, that is
not-
another scenario. That is because of the acute occlusion of the vessel.
In that
That's
scenario,
not a
there's a
CTO.
need, or there's a need of, or at that time, that patient is your patient is in cardiogenic shock, and where I think we need the IBP in that case, but not here because this is
In
an
this
elective
patient.
case.
No, sir. The question Dr. Abdul Hakim did
Move nahi kar raha.
in SVG to LAD, we need systolic pressure. In systole, blood flow from aorta to SVG. But for IABP, this is in this patient, this is not reason for aorta to SVG to LAD blood flow for IABP. IABP in this patient for backup, if we block SVG to LAD, like no flow, slow flow, then LV, left ventricle is normal and this RT is supplying to LV. So LV will become shut down. So for mechanical circulatory support, IABP will help. Yes, sir. You are agree with me?
Main function of IABP is to augment the
Any question from the?
But IABP will load off of LV and little bit support for LV, so you can complete your procedure.
I have a question about distant from this scenario that you are asking. Why do you think I can say when the vein is in the native position, it means in the normal position, it has less atherosclerotic risk as compared to when it is placed in the artery or it is placed in the heart? What is the mechanism behind it? What do you think?
Repeat the question.
When is native position? When is in a native position, the risk of atherosclerosis is very low, as compared to when it is harvested to the artery in the heart.
I don't know what is the exactly, but 2-3 points, because its natural position, flow is integrated, there is valve in the veins, and in this you are putting the reverse positions, and this is not at proper flow, this is, and it's connected to artery. Further, Dr. Abdul Hakim will guide us.
If I got your question, so you are talking about the SVG putting in the artery. So you got just arterialization of the venous graft. The chances of degeneration are more in SVG graft, and the complication rate is also more if you agree for the intervention. As I don't know the exact finding what you guys want to do, either go for the heart team or go for the PCI directly.
No, wait a minute. You guys didn't answer my question. It's very hard for you to dodge this question. Mahesh is asking, we all have veins in our legs, but we've never had any consequences of that. Why is it that you put a vein graft and 18 years later it is 99% stenosis? What is the mechanism? What is the predominant mechanism?
Mechanism is that you are putting a venous graft in the arterial system. So you are just arterializing the venous graft. So the tear is more in the venous. That's why the degenerative process is more. And there's the limit. If I am
He knows the answer. He's just trying to be academic. He knows the answer. He's just trying to.
And okay. And another thing.
Shabir wants to answer it.
There is a basic difference between the vein and artery. We must all remember. Vein is sparse in endothelium, and it's not koi veda vasorum nahi hai. And arteries are tensile and plus abundant endothelium that releases the vasodilators that keep the artery patent. And vesa vasorum is also there, and smooth muscle cell is abundant in arteries. and veins are hollow, lumen is small. So that's why when you graft the vein to the artery, there is a natural mismatch. You are anastomoting the artery to the vein. And second is degeneration is a more enhanced in the veins as compared to the arteries.
Do you agree, Mahesh? And sir?
Dr. Sanam wants to say something. Yeah.
Just wanted to add that in this case, we are debating over that we are going to do a redo cabbage or we are going to attempt SVG ostial PCI. We already said that we don't have an arterial chordate available. Is there any convincing evidence which will prepare a heart team over a direct PCI to this ostial SVG?
Second, the age of the patient is 70 years.
Yeah, multiple factors. Actually, you can see the 3 vessel disease, only one graph is patent. That is also affected, severely affected. If you want to go for the surgery, you need to complete revascularization this patient. So you don't have an adequate cardia available for the complete revascularization. And a gastroepipelic is a very small graph. You can't put a gastroepipelic in a LAD or in the, so another thing. Yes. So this
agree with all. But
Doctor Dasti want any comment?
क्वेश्चन ये था कि ये सिंगल वेसल है जो लाइफ लाइन है।
Yes.
इससे पहले क्या हम इसको आरसीए को अटेंड कर सकते हैं?
So we don't know.
Can I answer?
So why
You can.
I want to answer about this question. That if, with the territory that is supplying through RCA, I think it's better to intervene the LAD. But I'm against the intervention of LAD in this case, considering the age of the patient and the volume of the contrast. So, what is the most simple and safe way in this patient to intervene? I think first intervene there. If we reverse this patient through SVG, PCI, then after that, if our patient is symptomatic, then we can consider for CTO intervention of RCA. We will.
सीटीओ का जो फार्मूला है उसमें जो है ना कल्प्रेट को ऊपर लेना करें, मतलब आगे के लाइफ लाइन को ऊपर लेना करें, पहले जो सीटीओ उनको पहले सपोर्ट कीजिए, बाद में आप लाइफ लाइन कीजिए।
आपका जो है ना ये सवाल वैलिड है, लेकिन इस एरिया में जो आपकी कल्प्रिट वेसल है, दिस इज़ द ओनली सिंगल वेसल और वो 99% ब्लॉक है विथ इवन टिमी 3 फ्लो, यू कैन से 2.5 आर्टरी। तो आप इसको जब वहाँ इंटरवेन करेंगे और अगर ये ब्लॉक हो जाए तो दिस इज अनस्टेबल, पेशेंट हैव अनस्टेबल एंजाइना, सो इन दिस सिनेरियो यू कांट गो फॉर सीटीओ, यू शुड do the PCI of this vessel with all measures, you can safety measures just like embolic protection device, IABP just already mentioned. So you can directly go for PCI to SVG to LAD in this patient.
Okay, so this patient was discussed in her team in 2 different surgeons. He refuses that we already discussed the points that because of the inner age was 70, that's why. So I just want to show you the anatomical influencing factors for revascular decision. As we already discussed this, those which patients they go for the PCI if there is a patent arterial graft, especially LAD. If the LAD graft is disease along with LV dysfunction, as we already discussed in the previous talks, and more than 3 culprits lesion and multiple SVG lesions and available artery condy, you can send this patient for the cabbage. If there is unavailability of the condy, you can do for the percutaneous intervention.
Jahangir, 1 minute. This slide, just this slide. इस स्लाइड से आपके काफ़ी सवालों के जवाब क्लियर हो गए कि हम अगर अपने पेशेंट को इस स्लाइड में फिट करें तो जो लीड टू केबेज वाले ऑप्शंस में से 2-3 पॉइंट्स इस पेशेंट में नहीं है, 1 पॉइंट है। तो दैट्स वाई अगेन फ्रॉम दिस स्लाइड फ्रॉम एविडेंस वी कैन गो टू PCI to SVG.
Okay, there are other points also, patient having a posterior lateral target such as the dominant circumflex and also a mediastinal scarring, they are not fit for the surgery. Okay, so what are the general consideration? I just want to, these are the 11 points if you are planning for the intervention of the SVG graft. So you should prefer PCI of native coronary vessel if it's feasible. But less complex, you can directly stent. It is feasible to go with the native coronary artery. If, especially if the SVG graft is degenerated. And avoid balloon pre-dilatation, post-dilatation is better to prevent the peri-procedure MI and the risk of no reflow because it's very high. And put an embolic protection device in these patients and utilize microvascular vasodilation throughout the procedure, before, during stenting, because it will even prevent the no reflow and also treat the slow flow also. And if the post-dilatation perform size is not more than 1:1, and putting a perform slow and prolonged stent and balloon inflation at a nominal pressure. And consider slightly undersized stent but a longer stent, because if you take an undersized stent, the chances of plaque eruption are less, and the no reflow and peri-procedure MI is compared to you take an oversized stent is high. And consider thrombectomy. If you see the large thrombus burden, you just aspirate the thrombus and keep activated clotting. Activated clotting time is higher as compared to the coronary PCI. And consider prolonged dual antiplatelet therapy, the DAPT score. SVG intervention has the 2 points. If patient having a DAPT score 2 or more than 2, you can prolong the antiplatelet therapy. And what are the common technical problems? If you have to prepare yourself, because if you are planning for the SVG intervention, you should know what complication, what consequences you can face during the intervention of the
Dr. Jahangir, can I disturb you once at this moment? Talking about the embolic protection device, because we have seen in the data even, this has been overemphasized.
Underutilized. Okay, I will show you.
Less than 10%, 15%.
We have planned to discuss about EBD, but
so what are the common technical problem encountered during SVG PCI? You can see most of the SVG have a diffuse disease. You have to put a long stent. Restenosis rate is very high. Thrombus burden is high, so the distal embolization chances are very high. Mostly they are degenerative. You have to put a distal protection device. Again, you will see the adverse outcome. The distal embolization is very high in patient. Restenosis rate is high by putting a bare metal stent. So you put a diagluted stent. This is old data. Your new data I will share you later on. That shows there is no any difference of the diagluting stent or bare metal stent in SVG intervention. Retrograde embolization, if there is an ostial disease and there is a high thrombobundin, there are chances of stroke or any organ emboli is more in patient having a aorto-ostial SVG lesion. So as already mentioned which stent you will prefer, bare metal or diagluting stent. There are multiple trials in the 2006 to 16. They show the there was a restenosis rate was high in the bare metal stent, but there is no any difference in the initial phase, but long-term follow-up, they seen the restenosis was very high, and the target vessel revascularization was more in patient receiving a bare metal stent. But later on, the DIVA trial comes and they included, that was a multi-center trial that done in the 25 center. They choose patient having a 50 to 99% of the SVG lesion, divided into 2 groups, the patient receiving diagluting stent and bare metal stent, and they clinically follow after 12 months. And the outcome of this trial, the primary outcome show the target vessel failure and cardiac death, target MI, and secondary outcome you can see the cardiac death. There's no any difference. The final, there's no any difference between the bare metal stent and diagluting stent, even in the primary, secondary outcome or any safety outcome. So you can place any stent in SVG intervention. So what is the role of glycoprotein 2B, 3A in SVG? You all know there's no any role. It was proved in these 5 trials, EPIC, EPILOG, EPISTENT, MPECT and PURSUE. They compare with the placebo, there was no any role, even the bleeding resistance was high. Even with the distal embolic protection device, the use of glycoprotein 2BA, their mass rate was high. So now we have to use what are the embolic protection device and what is the indication. Although embolic protection device, it was this trial, SAFER trial, it was published in 2002. Then embolic protection device initially was class 1 indication. Later, as the Mahesh discussed, It was under use, then it's come to the class 2 indication, even in the American and European society. So they have seen initially when they compare with the routine SVG PCI with the percusage device, it's a distal protection device. So there was a 30-day mass rate was decreased up to 42% by using this embolic protection device. After this trial, the embolic protection device was class 1 indication. The time. So I just want to show you the percusage system, the guide wire system. You just cross the lesion and inflate the balloon, complete your PCI and aspirate the debris and just finish it off. You have also you have a filter wire spider XT system. You can see you just place it and just aspirate it. And you also have a proximal occlusion device too, but in ostial lesion you can't use it in proximal occlusion device. There was also a fire trial that shows is there any difference between the filter wire and the guard wire. There's no, the filter wire was non-inferior to the distal protection wire. So come back to the case. So my question to Dr. Atif, what will be your strategy for this if you are planning for the PCI to SVG? What will your guide selection? What will be the wire? How you will proceed? If you want to any balloon pump or any other mechanical supportive device, so how you will go?
Although you have already covered that general consideration for the SVG PCI already, but I would just like to embark upon a few more important points here. First of all, the approach. Are you going through a transfemoral approach or a transradial approach? As you have done it with a transfemoral approach, there is specific guide selections for patients who are going for an SVG PCI of the left side. You can go for a JR guide. You can go for a memory guider, IMA guide, and you can also go for a hockey stick guide and NAL implants 1 as well. So these are the guiders that you can use. However, you really do not need an extra backup support guide except the cases where there are more distal lesions. In such cases, you may need an extra backup kind of a guide, or if you want to put an embolic protection devices and that anticipated challenging has to be faced because of the distal protection devices. In such cases, you can have an extra backup support, but especially in your case, you really do not need an extra backup support because in aorto-ostial lesions, you don't need a good support because it already led to the dampening of the pressures while you were engaging with the diagnostic catheters as well. Now, if I talk about the wire selection, I would go for a soft workhorse wires because I don't need any special wire for this case. Third important point here in this case is the pre-dilatation. Usually and preferably we should avoid pre-dilating the SVG graft because of the risk of distal embolization in such cases. However, in your case, since it appears to be a significant narrowing of the aorto-ostial lesions, so probably you need to pre-dilate such lesions. And if you want to put an embolic protection device, then definitely that's an option. And while you are stenting, the better method would be direct stenting, and secondly, undersized, longer stent. Why? There is a specific reason behind that. Now, if you want to take an oversized stent or 1:1 stent, the problem is that there can be a plaque prolapse through the stent studs. If you really want to avoid that, you have to take an undersized, longer stent. And then post-dilatation again should be avoided if possible. Embolic aspiration thrombectomy, yes, if you are not using an embolic protection device and there is a high thrombus burden, probably in your case you won't be needing that.
I am talking about.
In your case, you won't be needing it, yeah.
Is there any?
No, I don't think so.
What do you think, Dr. Ammar?
I agree with Dr. Atif. One thing which we will do, if we will not use the embolic protection device, then we should use pre-medications to avoid the slow flow. That we should do. The rest, I agree with Dr. Atif to continue in the same manner.
Dr. Gulzar?
This is high takeoff. Third indication of guide support is the high takeoff SVG. So I think your case is high takeoff. maybe you feel difficulty to cross the lesion by balloon or stent, maybe you need a guide, support guide.
Okay, Dr. Bashir, what complication or what event you can observe while engaging guider in this lesion, and what measures you will have to do while doing PCI?
It's important because in aorto-ostial lesions, when we are talking about is this is in this patient, it looks like the stable plaque, but there are possibility of intervention in these cases. There are, or if this lesion is thrombotic, then the possibility of thromboembolism and stroke or in these cases are more common.
Another thing which I think should be done is that before engaging the guider, we should have a wire and a pre-dilating balloon inside the guider, because the pressures will damp and we will have a little time to intervene.
Yes, that's called hit and run technique. You have to take a guider that is soft tip. You don't have to take a guider which need extra support, because you feel difficulty to engage the ostial SVG. So you just load your wire. If you want to do the balloon, just load your balloon inside the guide and just engage the guider and just cross your wire and pull your guider back. Because if you will deeply engage the guider, the chances of ischemia, dampening, arrhythmia or dissection are more if you do this like that. So you have to just hit and run.
How come are you sure that someone will not be releasing any embolic protection device?
So embolic protection.
Javed, I did not talk about an embolic protection device. The question was raised about the aspiration thrombectomy, and I specifically said that since in this patient there is not a large thrombus burden, and we will be using an undersized longer stent, there won't be an element of a plaque protrusion through the stent starts. So I don't think that we would be needing an aspiration thrombectomy. However, as far as the role of embolic protection devices, definitely you should be using it, but we are not using it in an ICVD.
And what's the risk?
No.
That's a great question. It is recommended based on the different studies that they conducted, and they said that if you want to take a 1:1 on an oversized stent versus an undersized stent, they found that it is not absolutely necessary to approximate the stent starts to the vessel wall of the SVG, because then if you do that, there is a greater chances of distal embolization and the plaque prolapse. So the results were quite good in patients who were receiving an undersized longer stents. That's in a study, evidence-based.
So if you're talking about the embolic protection device, if you want to use the distal embolic protection device, you have to inflate the balloon proximal to the side branch. And will you do this in only a single artery that's supplying the whole myocardium? So the option is lost. Another, you want to put a filter wire, so you have to select the size according to the vessel. You have to if your SVG graft is 7 millimeter, 8 millimeter, so you have to choose the filter wire according to that size. So
much concern for this is the only pairing vessel in my body.
Yeah.
If the vessel is low, you have the time of embolization, especially going to collapse in the head. So that's why I'm concerned that one of the use part of the wire
So and secondly,
what do you think? The filter wire is easily crossed? I don't know. It's easily crossed from this lesion. Either may you need a pre-dilatation or not.
And secondly, Dr. Javed, I just want to add another point here is that, like they said, the studies have proven that in cases, if you are not going for an embolic protection devices, I mean, in such cases, it is especially essential to go for an undersized longer stents, especially in such cases. So in our scenarios, we are not going for EPDs. I mean, the best approach would be to just go for an undersized standing rather than an oversized or 1:1.
Okay, if I may just add, there's a lot of tension on whether embolic protection should be used or not. See, if you are to classify this lesion, number one, it's an ostial lesion. The most important thing about this lesion is an ostial lesion. And ostial lesions, by definition, have aortic tissue. And ostial lesions are almost never have fat in them. Okay, so there are two exceptions to the use of embolic protection in SVGs. One is ostial disease because the pathology is very different. They're not lipid rich, they don't have macrophages, they don't have clotting. That's the first thing. and second is the insertion site. And then if your lesion, you need to have at least a
30 to 40 millimeter.
30 to 40 millimeter landing zone.
Yeah.
For that is a non-issue here. But because it is predominantly ostial, I don't think you would be penalized if you were not to use. And
Yes.
more importantly, how would you get a filter wire across? Even getting a spider through a sheet would be difficult because this is a subtotal lesion. So I agree with the strategy that has been proposed, which would be to wire, balloon, and then put a stent. Again, because it's fibrotic, I'm not entirely sure if I would undersize in this case.
So I have decided to not use the embolic protection device, and I decided to wire it and pre-dilate. So I load the wire and balloon inside the guide and just do the pre-dilatation at a nominal pressure. I use just compliant balloon and inflate it at 12 atmosphere. So I just pull my guider out because continuously pressure was dampening. So I just pull out my guider into the aorta. This is the JR guide. So what will be the stent size? Atif continuously enforcing that you have to get a larger stent. So what do you suggest in this?
I think in this case we can do two things. One is that we can go for IVUS imaging. I really don't know whether did you go for IVUS in this case or not.
So IVUS.
Would IVUS help in this case?
So you want to confirm the size?
The sizing for the sizing purpose, yes.
So the question was, would IVUS help in this case? I still have to think of a lesion where IVUS would not help.
Yes.
So that question in itself is an oxymoron. IVUS will always give you more information.
Yeah.
We have cost constraints, so that is the only reason. It was rare in the US for me to do a PCI outside of an acute MI or without IVUS because cost was not an issue. Now, if I told you, you guys go ahead and you can use IVUS just like you use a 2O15 balloon, you would be shitting IVUS catheters, okay? So,
I just add 2 points in this case because one end of the stent in the aorta, so you don't worry about that size. And second, the distal segment of stent should be in the 3 to 4 mm in healthy segment. So just we squeeze the plaque towards the vessel wall and slightly undersizing the stent because plaque was 90 to 95%, and maybe you need a high pressure to inflate the stent.
So because you have to place your stent 1 to 2 milliliter inside the aorta to cover the ostium. Okay, so I choose 4O18 stent, that was regulating stent, because we don't have available bare metal stent in our catheter.
So what was your optimal view for placing the stent to the ostium?
That was already seen during the angiogram. I thought it was the LO view that was very optimum for me, in which the ostium of the SVG was clearly visualized. So I have just focused on that view because I don't want to give maximum dye to this patient. So already when I review the angiogram, then I've decided this is my view for putting a stent to cover the ostium of the SVG.
Here we see in
So I have taken in multiple view, but not give the scene in multiple view. This was the best view to see. For that, if you are discussing about whether I missed the ostium or not. So it's totally depend upon that. Sorry, I don't know exactly how much stent is proliferating, but the literature shows you have to place your stent 1 to 2 millimeter inside the aorta to cover the ostium.
I just want to add one.
What is the difference between the case in the left wing? It should be just outside the lower lip of the eye. And in this case, when you are receiving the APG ostial, they not should be the stage because to take the stage in that stage.
So it's very difficult to localize the ostium of the SVG. You don't know, we have taken multiple direction to see. But in which view you can see, you can just put another option in which we are using the other guide catheter, prox guide catheter, just place another landmark sign, just put a wire or anatomical landmark to see the ostium of the SVG.
In the left ostial stenting, we do have the landmarks. There is a vertical line.
Yeah.
We try to put the stent inside there. We don't have such landmark in this ideal practice. How to confirm the ostium is covered or not?
इसका तो बहुत आसान जवाब है। आपका स्टेंट कहाँ होगा? एओर्टा में होगा ना। 2 के बजाय 3 मिलीमीटर कर दें, क्या फ़र्क पड़ेगा? वो तो इतना बड़ा एओर्टा है, अगर 2-3 स्टड्स पीछे आ गए, उसको आप फ्लेयर अप अच्छा कर लें।
देखो
The issue is not कि 1 to 2 मीटर से 3 से 4 मिलीमीटर हो जाएगा तो कम नहीं पड़ेगा। Issue is that when you redo, when the patient will see intervention, how you go.
For that you have to flare up. So ideally flash balloon you need flash balloon. डॉक्टर नवीदुल्लाह ने आज ही बताया था। Ideally तो आप उससे बनाएं कि फिर आप आराम से engage करें।
अगर तो stent is more into the aorta, it's rending into the aorta, how can you flare?
अगर 4 mm में उसका फ्लेयर नहीं
कितना फ्लेयर कर
आपने फ्लैश बैलून शायद नहीं पढ़ा, आज डॉक्टर नवीदुल्लाह ने पढ़ाया भी था, उससे अच्छा फ्लेयर हो जाता है।
These are the complication of the ostial intervention. You just one thing is you just miss the ostium, you just overcome the ostium and you put a stent in the aorta.
Jahangir, can I
far,
add a few comments on it?
Yeah.
I think 2-3 points that I was feeling to worth mention. First of all, whenever we are having this kind of anatomy where your guide is supposed to be highly unstable, right? And I can 100% sure that your wiring will be a big task for you at that moment that you were doing. So it always been a good idea just to get another wire, just to give you a good support to the guide. One thing. Second thing is that yes, for all like left-sided graft, RO view is a good view just to see the start or the origin of the graft. So here you can have a bit better idea about the placement, because on one hand you will try to get into the aorta, on the other hand you will also try not to come into the aorta very far. So I think these are the two things, and I think the rest of the things,
as the command says, the left-sided SVG graft, you have a LO view and a RA view for the localization of the ostium. That was yeah. You can take help from this pro device also.
Ostium is difficulty to change the different views. If Gulzar says right, incidentally 3 or 4 studs came with aorta, there is no other option than flare.
You have a 2-3 option. Yeah, you just flare it. Yeah, just put a snare and just remove your stent. But the chances, okay.
Option is flare the stud by the ostium balloon. One thing is, if you miss the ostium, what you do next? If you miss the ostium, you know.
Look, if you miss the ostium, you have only one option. You have to place another stent. That's clear. If you put your stent more in the aorta, you just flare it. But you need the DAPT. You just continue DAPT for prolonged period of time. One thing. Another, if you want to just snare it out, but the chances of vessel injury are more, and you want to snare it out and put another stent. So there's a risk of SVG, no reflow, injury is very high in this patient. So these are the
purpose of this question.
Yes, I agree. In SVG PCI, you need to prolong the DAPT, but keeping in mind the only on this point, your state is that they are 4 millimeter hanging in the aorta, and because of that reason, you have to prolong the ABA test.
no, that is it. That. Okay.
If you are not sure about the angulations and projections of ostium, then if you are not sure, then we can take the another wire for the landmark. That can help us.
It's quite difficult because your guider is in an unstable position. How can you confirm that your wire is just covering the ostium? So why you are complexing the case? There's the option to take another guider and just give injection with another guider and fix the ostium. Yeah. So.
Okay. All right. So I understand this is a huge challenge. The best way of doing this is to get the guide inside the ostium till the waveform, dampens. You pull the stent right to the mouth of the guide, and then you pull both back as one unit. And you keep taking small shots, and then you're also focusing on the waveform. As soon as the waveform recovers, you pull the stent back another dot. That way, you don't have to see, but physiologically, you've proven that you've come out in the aorta. Okay.
Very good point.
Because you just cannot see the ostium. You cannot see ostium of vein grafts they're coming from. If this is more difficult to do because, say, you've got an AL guide and you can't do that, so the simplest thing is to take a guide liner and do the same thing.
Yeah.
With the guide liner, advance the guide liner till the waveform dampens, and then gradually keep pulling it back, and adjust your stent accordingly. And as soon as the pressure recovers, you know that that's the true ostium. Pull the dot back another dot or two, and you will be pretty certain. But the more important thing, and I agree with Jahangir, I would rather pull the stent back 3, 4, even 5 millimeters in the aorta than to miss it. Because again, like I said, the highest risk of restenosis is with
missing
ostial, because that's aortic tissue that has a lot of elastin in it, and the stent. These are all open cell designs. They don't have supportive ladders as they used to initially. So the stent tends to collapse. So you would rather have more stent out than in. And then you don't want 2 layers of stents in the ostium, because that's an ideal recipe for failure. And for this guy who's relatively young, he's living off of this.
So another, the Zebu technique, that was used to cover the ostium, you put a wire in the proximal studs of the stent and just keep the wire inside. In the aorto-ostial lesion, But
और सबसे इम्पॉर्टेंट चीज़ इस केस में, हम इस केस की बात कर रहे हैं. इस केस में आप जेबो टेक्निक, गाइडर इंगेज, डीप, इसमें नहीं करेंगे. इसमें 2-3 स्टेट्स बार.
To me, that was the view I found best to see those.
Okay, let's see what you get.
So I start and slowly inflate the stent, and initially you can see the in previous angiogram there was a clear waist in the mid of the stent. This is the point where I have inflated at 16-18 atmosphere, but there was a waist. So I stop here and just pull back my balloon. While pulling back the balloon, I just lost my guider and wire, and I lost the access. So again, I've crossed one wire, and at that time I took another wire and confirmed it either my wire is going through the studs, not going through the studs. I confirmed it the smaller balloon 2015. It was easily crossing through the stent. So I decided to take a 408 NC balloon and inflated at 18-20 atmosphere only at the site of the under-expanded segment and in flaring of the ostium. And this was the result after. Sorry? You know the other longitudinal, already discussed longitudinal deformity. You can see while you are wanting to engage the guider, you will lead to this complication. Yeah. So avoid engagement of the guider after putting a stent, because you may face up with these complications.
Just right with the balloon, you are taking this.
Yeah, you can do this. You can do this if you. So this is takeoff angle. It was very difficult. At one time I just engaged the ostium of the SVG. So these are the final results. 408 NC at 18 atmosphere.
Now you have to fix the lateral.
Why? We have to assess the patient either its angina improve or not, because he present with unstable angina CCS3. This patient was visited in my OPD. He was doing fine. His angina class is improved, and he was very happy. Actually, he was my private patient. That's why initially I used a single wire. If he becomes symptomatic, then we'll see. A 70-year-old male, you want to do the complete revascularization, we'll do it CTO, opening up the LAD in CTO. Okay. So as we already discussed, the option for improved outcome, direct stenting, embolic protection device, the vasodilator use, stent size, and the thrombus management. So my next talk is about, I just want to two, three slides upon the aorto-ostial. So high time. Just only 2-3 slides. Okay? So the aorto-ostial lesion arising within the 3 to 5 millimeter of origin. It may be SVG, aorto-SVG, aorto-RCA or left main. So because these aorto-ostial lesion, they are fibrotic, their restenosis rate is very high, they are difficult to engage, and their complications are more, and few the guide support is very poor for intervention of the any aorto-ostial lesion. So you have to already think and about these the risk you can face during intervention of the aorto-ostial lesion. So if the patient had a prior CTA, the problem is that you can see if the CTA is available, you can see the view in which you can easily see the ostium with the help of CTA. If RCA, you usually use steep LO view, and left main use both LO or caudal view. SVG view, you can use the LO view, but should check in both LO and RA. We have already seen in this case. So these are the points we already discussed: the dampening of the pressure, ischemia. I will just omit this. This is the septal wire technique. You just put a wire in the cusp and to confirm where is the ostium. And as Dr. Hakim is told about the guide extension, you can just cross the guide extension and just give flash to see the ostium. This is the OsteoPro device. You can use this, but the use of this guider is also controversial. You don't have any idea. So how to overcome the excessive motion during stent deployment? And this is mostly seen in the RCA, and you can just tell the patient just hold the breathe and just cover the ostium. You can give adenosine to just decrease the rate and just fix the ostium. And while you are performing stenting of the aorto-ostial, you should know which stent you are using. You can see the Zion's stent start from the proximal marker, and the rest of the stent is seen after the proximal marker. IVUS is also very important to see the geographic miss of the ostium. You can see the under expansion or any complication like preparation of the ostium by using a higher pressure balloon or atherectomy. So as we already discussed, these all the hit and run technique. As Dr. Abdul Hakim said, that you just cross the stent accordingly and deep your guider. This is the technique. Then pull your guider out with the double hand technique and confirm your position with the die through this guide and inflate it, and try to inflate the ostium through the same balloon flaring technique. You have another option: just use a NC balloon, or you can use a ostial flash balloon. Ostial flash balloon have a two portion. There's a distal portion, has a 1:1 dilatation, and the proximal soft balloon, you can just flare the ostial part of the stent. This is a geographical miss. What problem we already discussed this all. Missing the ostium, excessive stent overhanging, and the under expansion are recoil. These are the three problems you can face while fixing the ostium. So missing the ostium or excessive stent, how you will prevent multiple projection, long stent, breathe hold technique, rapid passing, or petal, or the floating wire, osteal device, or just Zebu technique. And excessive stent, overhang treatment, you just flare with the flare ostium balloon, ostial flash balloon, prolonged DAPT, or just snare it out. Or under expansion is a very common problem you can see in the aorto-ostial lesion, in which you have to prepare the bed with pre-dilatation, aggressive pre-dilatation with the high pressure balloon, leg modification with the atherectomy and all, and you can leave the laser with contrast, intracorneal lithotripsy, or OPN balloons, but sometimes you will observe there the recoil rate is very high. So you can see a peripheral stent, just like a renal stent, they have a high radial force, and the recoil of these stents are lower as compared to the other stent. Thank you very much.